Good afternoon, everyone. Welcome to Ask the Experts, our lung cancer prevention and screening webinar this afternoon here. Thank you for joining us for our virtual event. Our intention is to provide a space for sharing of information, resources, and to answer any questions about lung cancer screening and prevention. We will have a question and answer time at the end of the presentation. Feel free to submit your questions via the chat, or if you're comfortable towards the end and would like to be unmuted so you can speak directly, just let us know and we can do that. Currently, all participants are muted and unable to speak verbally in the presentation. We've mastered the chat function this morning. Everyone was able to use that. So if you do have an urgent question for one of the speakers, feel free to put it in there. I will be monitoring that and can have the speaker address your question. And then just a little reminder, this event is being recorded. So all and any personal questions will be removed and edited out. We had some facilities for long-term care ask us if we could possibly record this and share it with them so that their tenants could view it as well. So with that, I'm going to pass it over to Kelly here and we'll get started.
Today we have Jacob Anson, Health Promotions Coordinator from Wright County, here to speak about tobacco and e-cigarette health impacts. Take it away, Jacob.
Thank you. Can everyone hear me?
Yes.
Awesome. All right, so I'll be talking largely about e-cigarettes today. You can go ahead and go to the next slide. So it's gonna be a pretty quick presentation today, but we're gonna be talking about what e-cigarettes look like, what's in the products, and the health impacts. Go ahead and go to the next slide. So what do e-cigarettes look like? When I talk about e-cigarettes, I really break them down into three different categories. So pens, mods, Juul, and Juul-like devices. So when I'm talking about e-cigarettes, I'm talking about there's a lot of different terms that individuals will use for the act of using the device. So they may just say I'm using an e-cigarette. They may say they are using a vape, they're vaping. Depending on what products they're using, they might be say they're juuling. A lot of these terms have come up and come about as e-cigarettes have gained in popularity to talk and use vernacular that people may not recognize about these devices. This presentation that I'm giving was in some way, shape, or form given to all of the area schools within Wright County, because as many of you probably know, within the last 2 or 3 years, we've seen a huge uptick in the amount of vaping or e-cigarette use in schools. Go ahead and go to the next slide. So the first one I'll be talking about is pens. So with e-cigarettes, the general type you'll hear about are e-cigarette pens. They're small, they're discreet. As you can see on the screen, the one in the center there, when they first came out, companies really wanted e-cigarettes to look like traditional tobacco products, in a sense, look like normal cigarettes. What companies have quickly found out is that most individuals that are younger, or most individuals that are in younger generations, don't want to think they're actually using traditional tobacco, so they don't want to associate e-cigarettes with traditional cigarettes. So the companies gravitated towards something smaller, something more sleek, such as the thing towards the top right there. With pens, these are ones that are going to be traditionally found in a lot of gas stations. They're going to be single use in a sense of you're going to use up what's inside of the e-cigarette, and then you're going to throw it away and buy a new one. But I would say the big takeaway is we have really seen that individuals in older generations don't in large droves come to use e-cigarettes from traditional tobacco. What we really see is that a lot of the e-cigarettes are marketed towards younger individuals and aren't really made to look or even be categorized with traditional tobacco in those adolescents' minds. Go ahead and go to the next slide. The next category I'll talk about are mods. So real quick, mods are the big bulky e-cigarettes that people tend to think of when they think of avid vapors. The ones that are going to have big tanks, big cartridges, the ones that when you're driving down the road and you see someone blow a huge cloud of smoke or vapor out of their window, this is what they're using. So the picture there in the center is actually from, I guess there's an international vaping cloud blowing championship, and this was the 2016 winner. I'm sure all of you are as impressed as I am by that cloud, but these devices really, they're called mods by the fact that you can change out any of the components of the devices. So with these ones, you can change out the tanks so you can store more in them. You can change out the heating elements so they heat up faster, and you can change out the batteries to either, some reasons you might change them is one, you might want to blow bigger clouds with it. Two, you might be using a different substance in there than the e-cigarette juice. Or you may just be wanting to tweak it and change how it works. So with these ones, if an individual is using these, they have to specifically buy juice from vape shops or tobacco shops, fill up that silver cylinder on top of the rightmost picture there, and then they will push down a button and use it. These ones tend to be pricier. So if we're talking about adolescents, they don't gravitate towards these ones as much, just due to the fact of the cost that's associated with getting involved in them. You can go to the next slide. Next, I'll be talking about Juul and Juul-like devices. So first off, starting talking about Juul. Juul was a brand of e-cigarette that really became popular in probably the last 5 years. This is the one that a lot of people associate with more of the restrictions that we've seen on e-cigarettes and vaping. Juuls have a very, very interesting history of how they came about and how they became so popular. So when we talk about Juuls, they are very sleek, very slim, as you can see there. Many a times they look just like flash drives. The top black part there on the device to the far right is where the juice is stored. And what happens with these is you would buy a starter kit, and with those you would put on new cartridges that have different flavors. With adolescents, we really saw individuals gravitate towards fruit flavors and stuff like that. The one thing that is very different about Juul is the type of nicotine that they use in these devices. So all the devices I've been talking about use some sort of nicotine. Largely, it's going to be some sort of artificial nicotine. With Juul, though, what they figured out to do as a company was make nicotine that is concentrated crystals of nicotine, basically, and it's diluted in a very small amount of liquid. So what that means is individuals that are using these devices get an extreme buzz extremely quickly off of it, and then will get a crash. As with many addictive substances, you seek that buzz, you seek that high. So if you are getting a big high and then coming down and then you're going to want to seek a bigger high again, and you're going to start building that addiction very quickly. With these also, we see, in many of these e-cigarettes, we see a lot of additives in the products, and we see a lot of variation from product to product. You can go to the next slide. The one thing that we did find out from Juul was it is widely popular amongst adolescents. Again, I'll be talking about youth largely here, as we are seeing that mostly youth are using e-cigarettes. So the statistic is a few years old now, but 15 to 17-year-olds are 16 times more likely to use a Juul compared to those ages 25 to 34. So the reason this statistic is so important is many of the times when Juul was advertising, or these other companies that are like other e-cigarettes companies were advertising, it was really geared towards telling people that they should switch from traditional tobacco, such as cigarettes, to these e-cigarettes, and trying to make the argument that they're going to help you quit using tobacco. Traditional tobacco, that is. What we've seen is that that's not true. What we usually see with a lot of these products is many people using both. So they'll use e-cigarettes where it's widely socially, where it is socially, so it is socially acceptable, to use them, such as when they're in cars or when they're in home, and then using traditional tobacco such as cigarettes where it's socially acceptable to use those outside, stuff like that. So we see a co-use with these. You can go to the next slide. Because of Juul's wide popularity, you go to the next slide. That's again a picture of the starter kit and a picture of the vapor that would come out, which is very small. When Juul became very popular, we saw a lot of other companies jump on board of these nicotine salts, these concentrated nicotine juices, these really concentrated nicotine juices. So you have two devices here, which again, you'll realize look very sleek, very slim, but have that same blend of nicotine salts, nicotine crystals in them that really drive that addiction. Go to the next slide. And then the next one after that. So we'll talk about what's in the products. So when we're talking about e-cigarettes, one of the addictives, one of the largest addictive substances in it is going to be that nicotine piece. The nice in quotations here, nice thing about nicotine is we know what it does to the body. We've really studied it for quite a while. So when we're talking about the health impacts of these chemicals in this, we really know what nicotine does. It increases the heart rate. It causes arterial damage. It causes a lot of that stuff that we know about. The other things in e-cigarettes are some of the very surprising things and things that we wouldn't see in traditional tobacco as much. Specifically lead, tin, nickel. These are with not technically within the juice, but within the heating elements of e-cigarettes. So if you look at the picture on the right, you'll see what is kind of like a cotton ball stuffed into those circular wires there. That's the heating element. So that cotton absorbs the juice, that heating element heats up, causes that liquid that's been absorbed to vaporize, and then they inhale it. Well, what we have found is a lot of these companies, believe it or not, are in to make a profit out of these things. So what they do is they use very cheap metals on those heating elements, the cheapest they can get. So what that leads us to is that lead, tin, and nickel, those heavy elements, breaking down in the heating elements and then being inhaled by the users. So we're talking heavy metals being directly inhaled to the lungs, which is causing lung damage. Some of the other things in here, formaldehyde, we know that is carcinogenic, so we know it does cause cancer, and it is something that is in the vast majority of juices as a preservative, and individuals are inhaling it. Propylene glycol is what makes the cloud of smoke. So again, it has been known to be damaging when it's heated up, and that is exactly what's happening with this juice. It's heated up very rapidly. Sorry. Some of these other chemicals are known carcinogens. And then one of these in particular, diacetyl, has been known to cause lung damage. And speaking of lung damage, what we know from e-cigarettes is it is true that it doesn't really cause as much of the black lung. You won't see a lung that is completely black covered in tar with e-cigarettes. But what happens more with e-cigarettes when it comes to health impacts is it's causing small lung damage. So it's causing damage directly where that air transfer is happening in the lungs, leading to increases risk of cancer, leading to those type of things that happen. The other large health impact that we're seeing really come out from e-cigarettes is the fact that a lot of these chemicals dry out your mouth and really, really stick to your teeth. So we're seeing tooth loss, tooth decay, some gum damage, stuff like that, that long-term could lead to cancer and or a loss in quality of life due to the damage that it's causing to the teeth. You can go to the next slide. So health impacts, I already talked about some of these. You can go to the next slide. But on the left here, you'll see what we know, that nicotine does to the body. And again, the vast majority of these juices are going to contain nicotine in them. The one thing that we do know, which has been very interesting, is some studies have tested the juices and have found that many of the zero nicotine juices, which are out there, actually contain nicotine. Again, these companies are out to make money, so they're produced in the same facilities as those that create juices that have nicotine in them. Thus, there's a cross pollution effect there that causes the zero nicotine juices to still contain nicotine. You can go to the next slide. So here's my information. I know I'll have a question and answer session after this. The one last thing I'd want to talk about is many of you may know that Tobacco 21 and some of those things have come into effect. We're still waiting to see how drastically that drops youth tobacco use, but is one thing that I would say within the last year has come into effect, and we're hoping will reduce that adolescent use. And that's all I got.
Wow, that was a lot of good information, Jacob. Next up, we have Mark Katz, who represents the Minnesota Department of Health. He will speak about radon considerations for Wright County. Go ahead, Mark.
Hello, do you hear me now? Can someone be in the chat and just let me know that they can hear me, please?
We can hear you, Mark.
Oh, great, thank you. All right, so I want to thank Virginia Health and Allina Health and Virginia Piper Cancer Institute for having me here. I am with the Minnesota Department of Health. And I wanted to talk a little bit about radon in Minnesota and also in Wright County in particular. And you can change the slide. So I wanted to get into some basics for radon. I want to talk a little bit about what is radon, where is it found, how does it get into the home. I'll talk a little bit about radon in Wright County and also in Minnesota, and then how to test and when to mitigate. So first off, what is radon? And so radon is a colorless, odorless, tasteless gas. The thing with it is even though we can't tell it's there, it is a radioactive gas. It's from the breakdown of uranium, which is fairly common in Minnesota. Matter of fact, uranium is common in southwest of Minnesota more than anywhere else. And with that, we do have higher levels of radon in that area of Minnesota. Now, uranium leads to the breakdown to radon. And because radon is radioactive, it does lead to an increased risk of lung cancer, even those who are non-smokers. You go ahead and change the slide. So as we get into some radon basics, I talked a little bit about uranium and radium, and that's in the soil naturally. And what happens is radon gets drawn into the home from the soil, so it come up through the basement, and it begins to concentrate in the home. Outside, radon isn't a problem. It's a natural gas. It's around 0.3. We use the unit of measure, picocuries per liter in the air, so it's very small. But at home, it concentrates in the air and gets up to pretty high level. So it's always important, no matter where you live and about your house, no matter what type of house you have, you go ahead and test your home. So go ahead to the next slide, please. So this is more about radon pathways. So we're getting a little more detailed here, but I just wanted to point out that when I mentioned radon and radon going into the basement, there are different ways the radon gets into the home. Now, one of the biggest ways really is just any soil that's in contact with the home itself. So we look at things like a sump pump, the floor wall joints, which are the joints between like the wall and the floor in the basement, kind of if that's opened up. Or crawl spaces are a good one too. So anywhere that air can flow into the home through the basement are avenues or pathways where the radon could enter into the home. Let me go ahead to the next slide, please. So I wanted to talk a little bit about basically pathways that drive radon into the home, or what we call a driving force. And there are three main driving forces that bring radon into the home. The first one we talk about is like a stack effect. You think of it this way, it's hot air rising. When hot air rises, it leaves the home. But we want to know where, when the hot air rises and leaves the home, it has to get air from somewhere. So it usually pulls air from the basement or from the lower level. And then the radon enters in there. And that's why Minnesota homes are generally a little bit higher in radon, because we're heating air for 6 months of the year. And so our radon levels are a bit higher than other states, partly because of how the home operates. The other thing is a downwind draft effect. We say that don't test your home for radon during stormy weather or barometer pressure is pretty high or low, because that affects how the wind pushes the radon into the home. And the last thing is just the vacuum effect. And basically what we're talking about there is if you have, for instance, a range hood or anything, or a fan in the bathroom where it's sucking out air. And if it sucks mechanically out air, then air has to be replaced from somewhere. And again, it just tugs on that soil gas and brings radon in that way. So really my point is that we don't know, don't depend on what your neighbor had for a radon level. Don't depend on the county having low radon levels. You should always test your home no matter what, because homes are each individually different in how they operate. Okay, next slide. So the Environmental Protection Agency, or the EPA, did a number of studies, and they found that radon accounts for about 21,000 lung cancer deaths per year, or 2,900 of those being non-smoker related deaths. And so it is something that we are concerned about, and why we're talking about it. And why we want everyone to test their home for radon. It's a very simple thing, but just to reduce your risk of lung cancer by just simply testing. And if high, then putting in a mitigation system would, save you that risk. And so that's what we're here about today. Go on to the next slide, please. So the Environmental Protection Agency has established an action level for radon. The action level is 4 picocuries per liter, but it was set back in the 1980s. Today, many professionals can get that radon level down to 3, 2, or even 1 picocuries per liter. So it might be worthwhile to take an action between 2 and 4 picocuries per liter, even though the action level, the level at which we say you should install a radon mitigation system, is 4 picocuries per liter or more. The indoor average level in Minnesota is 4.5 picocuries per liter. The indoor average outside of Minnesota, but for the United States, is only 1.3 picocuries per liter. So about 3 times more in Minnesota. 2 and 5 homes have very high radon levels, 4 or more in Minnesota. So that's about 40%. So 40% of homes have high radon. And because it leads to an increased risk of lung cancer because of its radioactivity for radon, we always just try to, tell everyone to go ahead and test, because 40% is a pretty high number, and the rest of the United States generally isn't as high as us. So it's important to test, especially here in Minnesota. Go ahead to the next slide. Oh, whoops. So the average radon, as I said, is 0.4, that's outside, and 1.3 inside. Just briefly, outside isn't a problem because it doesn't concentrate. It's free to go its own way. So it's very low. But inside, where it concentrates, especially during the wintertime, where we're always pulling in soil gas, it is imperative that we do test, especially during the wintertime, where we're going to get a reading that's going to be a little bit higher, about 1 picocurie per liter higher than if it was done during the summertime. Go to the next slide. So I wanted to talk a little bit about Wright County. And Wright County is even higher than the rest of Minnesota. So there are about 2.5 or 5 out of 10 homes that have high radon levels in Minnesota. And the average level, while in Minnesota is 4.5, in Wright County it is 4.8. So it's a little bit higher. So if we do live in Wright County, it may not be the best time right now to test, but it would be better to test during the summertime. But I should say, when we do test, we want our windows closed. Basically, if we have our windows open, it kind of dilutes the radon level. So we want to keep them closed. So with this heat wave, it's actually not a bad time to test right now because we have our air conditioning on. So with our air conditioning on, and maybe not a bad time to test right now too. Go ahead to the next slide. This is the website. I'm not going to go into it, but this is the website we could find on the NDH webpage. And basically, it's a map of all of the counties in Minnesota and then the radon levels. We have 4 picocuries per liter on the right-hand side, and what's the percentage of homes that have been tested at 4 or greater. And then we have 2 or greater too, because we say 2 or more, let's think about testing for radon. 4 is the action level. So we have those 2. So you can go, just Google MDH, radon data, and you'll find this map yourself. And you could look if you live in a different county, or we have another map, which I didn't show, which is for zip codes. And you can look for zip codes as well and see what that particular zip code is. So it's a very fine, detailed map. And I implore you to go ahead and take a look at it. It's kind of a nice little thing to look at and gives you an idea of what radon levels are, even in your neck of the woods down to the zip code level. Go into the next slide. All right, so this is something I just wanted to put in here. And the health risks from radon can be very high. For non-smokers who basically are exposed to 4 picocuries per liter, again, the action level, over their lifetime, an average level found in homes is at the 4, pretty much, that you have a 7 in 1,000 chance of developing or dying from lung cancer. So that's kind of a 1% chance. Now, granted, it's over a lifetime, and most people aren't in a home over a lifetime, and radon levels change. But being that the average here in Minnesota is around 4, we're pretty much exposed to that 4 when we're inside, especially the last year with that pandemic, we've been inside a lot more. So, with that 1% chance of lung cancer, it's really a great idea just to go ahead and test. So we just limit that risk because it's a little bit higher than we think about. When I go to the next page, there are some ways to test for radon. There are two different ways called a short-term test or a long-term test. A short-term is kind of a quick screening tool or mechanism that we would use to test our home. Now we'd want to close up the home because they're only going to be tested for 2 to 5 days with the short-term radon test kit, I believe. And so we put it in an area that we are commonly in, like maybe a bedroom or a living room. And we'd let it sit for those 2 to 7 days, and we bring it in, we mail it in. I'll talk a little bit more about that, and then we get the results back. So it's a very easy way to find out what your radon levels are. There is also a long-term test, which is basically taking into track of seasonal variations, where I said winter is a little bit higher and summer is a little bit less. Long-term, we can measure from 90 to 365 days. We usually say to include the season of winter in there. But by measuring through a long-term test, we get a very accurate level of what the radon levels are in the home. And what they do is there's a little piece of plastic that you don't see in that long-term test kit. And radon, the alpha particles of that part of the radiation, basically creates pot marks in the plastic. And they can count the amount of pot marks in the plastic, divided by the number of days that you have off, and get a good idea of how much radon you have in the home. So those are two ways you can do that. Go ahead and next slide, please. So there's the charcoal test kit and the continuous radon monitor. They're used for the short-term test kit. The activated charcoal absorbs the surrounding air, and it's hung up for 2 to 7 days. After it's done, you mail it in, and you will get the results back in about a week's time. So it's a very short amount of time. You get easy, quick results, and it's also fairly cheap. You could probably get it at Wright County for, I think it's $5, or at the Department of Health for $10. The continuous radon monitor is used in a real estate transaction where you don't have 2 to 7 days. This is done in a shorter period of time, and a professional who is licensed will put it in your generally areas like your basement or other areas that are near a foundation. And they'll know where to put it, and they put it up for generally 48 hours, and then they get the results back instantaneously. And what's good about this is for real estate transactions, it's very quick, and you can't like move it or can't open a window. And some people, like with real estate transactions, might want to open a window to get the radon levels lower, but it will know that. So for real estate transactions, that's the way to go to make sure that you have accurate results and people aren't trying to mess with the system. Go ahead to the next slide, please. So the Alpha Track is the long-term test kit. So we already talked about that, and the lab analyzes that too. So those are the two ways to go. Next slide. You want to place the test in the lowest livable area. During a real estate transaction, that would be the basement. But if it's not a real estate transaction, you put it in an area you're regularly in, like more than 6 hours a day or something like that you're in. Exclude the kitchen or exclude the bathroom because, well, I hope you're not in the bathroom like 8 hours a day. That would be bad. But you don't want to have high moisture areas. So you would put it in like a bedroom or a living room. And you put it a little bit away from the walls just because of the air pressure and the wind, and then away from objects a little bit. And lastly, at breathing level, we say 20 inches above the floor, but you want to put it at a level where your mouth is. It might be 5 feet, depending on what your height is. If you're 4'5", it might be 4 feet. Or if you're concerned about your teenagers and they're really tall and growing to 6'5", and maybe you put it at 6 feet. But you generally want to put it at breathing level. Go to the next slide. So this is how to interpret the results. And it is a little complicated. And basically all we're really saying is you do an initial test. And after that, if the reading is 2 or more, you're going to do a second test. Because if it's low, that's great. Don't worry about it. Retest every 5 years. If it's 2 or more, do a second test. And if that second test is 4 or greater, then we do recommend that you install a radon mitigation system. But they're expensive, so test twice before you do that. Next slide. We have qualified radon mitigators that could come in and install a system. So if you do need it, there are licensed professionals that install it on a website. So you can just look on a website, put in your zip code, and find the person you need. Go ahead, next slide. Next slide, please. There we go. So, whoop, I don't know where the arrow came from, but mitigation basics, radon mitigation system diagram. This is a very basic system. You got a fan up top, usually in an unconditioned space, like an attic or even outside. It sucks the air like a straw out the outside top of the house from basically a hole that was dug on the bottom in the soil. So that's, and then you have these indicators, like an active notification monitor and a YouTube manometer that tell you that the fan is sucking the air out, because if the fan isn't sucking the air out, it's not doing its job. So it will have those indicators as well. Next slide. And retest, if you do put a mitigation system in, make sure to test to make sure it's working right away. You want to make sure the system's working, because if you don't test, and then a year later, you find out that that system was getting it not where you thought it was, then it might be hard to have that mitigator come back and fix it for free. So make sure you retest it right away. Next slide. So important takeaways. Radon is a common issue in Minnesota. It's very common. Second leading cause of lung cancer after smoking. Testing can be done by the owner. It's very simple. Or you can go ahead and hire a professional, like if you were doing a real estate transaction. The action level is 4, but even at 2 to 4, it may not be a bad idea to mitigate your home. We have a list of qualified professionals on our website, which is people who are licensed to do both testing and mitigation. So, and then the last part, which I think is an important part, to the next slide. You can get a radon test kit for $5 from Wright County Public Health. And that's the number. I'm not going to say it. You can go ahead and write that down. Or you can go to our Department of Health website, but hey, it's a little bit more expensive at mn.radon.com. But, and then we'll go ahead and mail it right to you for free. And that's the whole cost. There's no other cost but that. And that would be for the short-term radon test kit. So thank you very much for your time. I really appreciate it.
That was very educational. Thank you, Mark. Who knew Wright County has such high levels? All participants will receive a free radon kit today if you give us your contact information. Also, participants complete the post-webinar questionnaire to be entered into a drawing for $25 in Buffalo Bucks to be used at local merchants. It is my pleasure to introduce Dr. Seth Baker from Allina Health, who specializes in pulmonary medicine. Today, Dr. Baker will present on preventative testing, low-dose lung screening. Dr. Baker?
Thank you. Thank you, Kelly. Oop, oop. All right, are we good now? All right. Thank you for having me today. I appreciate that for this important topic. Next slide. All right, so today I'm going to talk about lung cancer screening and kind of the process. So in the beginning, I'll talk about screening, and then the process that happens after screening is done, just for people that, so they can understand which way things are going and how to follow up on the screening results. Next slide. So whenever you have a screening issue, whether it's in our case lung cancer or breast cancer, you always have to diagnose the problem, and our problem is lung cancer in particular. Lung cancer is the leading cause of cancer-related death in both men and women. The American Cancer Society estimates there's about 230,000 new lung cancer cases a year, with 150,000 deaths a year. The little picture on the right just shows the various estimated deaths, and you can see both for men and women, lung and bronchus are on the top. People think it's often the sex-related cancers like prostate or breast. They are more common, but they often do not cause more deaths. As for prevention is the most effective strategy in reducing lung cancer burden in the long term. And as some of the speakers were speaking before, 85% of lung cancer cases are actually associated with smoking. Radon being number 2 in our state, but mostly with the screening, we're dealing with smoking. Next slide, please. So this is just a picture. You know, you can find anything on Google, Google Images. This is not one of my patients, but this is a pretty classic CT scan that you can see in a lung, not necessarily screening program. Hopefully you'll pick it up before that. But there on the left lung, which is on our right side when you're looking at the screen, is a large mass, and there's actually a little bit of fluid around the lung too, but that's what we're trying to avoid happening. Next slide, please. So why do we screen? And the reason why is because outcomes for non-small cell lung cancer, which is about 80% of lung cancers, is directly related to the stage that you make at the time of the diagnosis. And there's actually a little less data for small cell lung cancer, but in general, and I think this goes along with most cancers, the earlier stage, the better, and the better survival. Also, in our particular patient population with lung cancer, 75% of lung cancers present with the advanced stage 3 or worse. And this is usually because symptoms don't really start until they're more advanced. So you may be going after, once we're diagnosing them in symptomatic patients, it's because they might have a symptom like coughing or wheezing or coughing up blood. So by that time, the cat's kind of out of the bag. And despite advances in therapy, so we're talking about newer advances in chemo and the surgical techniques and radiation and even the newer immunotherapies that you can't go watch TV tonight and not see commercials for some of the drugs, the overall 5-year survival of all lung cancer is still only 18%, which is pretty dismal. The slide on the right really kind of shows the differences. In A, that was actually the 7th edition of the lung cancers, basically diagnosis of stage. Where you see down to stage 4, it was a 6% chance that you're going to live 5 years with that diagnosis. Of course, as things get more complicated, the 8th edition, which was actually at the start of January of 2020, expanded on the stages. So there's a couple of there's a stage 3C in there. The 4s have been separated out into 4A and 4B. So there's more groups, but the point is made the same. As you can see, the 5-year survival definitely drops as the stage gets worse. So we're trying to diagnose at an earlier stage. Next slide, please. So why to screen? What are the benefits? Well, the goal is you're going to detect earlier cancers that are more amenable to cure. Lung cancer screening has been shown to have favorable rates on smoking cessation as well. And some people think that that's because if you're screening, all of a sudden I'm going to think, well, why am I doing the thing that I'm screening for? So they're going to try to quit smoking. Early detection leads to earlier treatment, which is usually more cost effective. And for those that don't like medical terms, just read that as less expensive than treatment at later stage. And then other illnesses and diagnoses that actually can be made sometimes with these screening CT scans. Next slide, please. But with any screening test, there are cons, there's harms of screening. So some of these are consequences of evaluating the abnormal findings. So you might need some sort of further imaging. You might need a biopsy or surgery for benign findings. The National Lung Screening Trial, which we're going to talk about a little bit more in another slide or two, really did look at about 30% of their screening CTs that had some sort of abnormal finding. And of those, the vast majority, 96%, were false positives, meaning in that case, they were not leading to a lung cancer diagnosis. So that doesn't mean that there's not important findings, but the reason why you did it was not the reason what led to the abnormal results. And actually in the trial, 11% of the time when an invasive study was needed, that was still false, there was still a lot of false positives with that. There was incidental findings also that could lead to other evaluations and follow-up testing, such as diagnosis like emphysema or coronary calcifications, and that can lead to patient worry. Obviously, there's also harms of screening because I get asked the question, well, what about radiation? So estimates do show that for every 108 lung cancers discovered by a screening, one major cancer might be induced by radiation. That's an awfully hard thing to prove. And for that one patient, that's terrible. But if you're looking at the overall pluses and negatives, obviously you see a big shift towards the positives. Obviously, this can cause patient distress. Frequently we'll see patients coming in with a lot of worry because of an abnormal screening test, and then the workup of that. And then there's actually overdiagnosis too, which you wouldn't think overdiagnosing lung cancer is a big deal, but what happens if you're diagnosing a lung cancer, you're overdiagnosing the lung cancer in somebody that it might have been clinically irrelevant, somebody that's got a really tiny cancer with terrible heart disease and really poor survival from their heart disease. So there are potential other screening harms that can happen. Next slide. So how do we screen? So these days it's a low dose CT scan. So low dose is lower radiation dose than the traditional CT scans. It's really on the order of about 5 times less radiation. It's more than an X-ray. It's about 5 times more radiation than an X-ray, but less than a routine CT. And the hope is, like this little picture shows, that you find out something that looks like that, something small. Next slide. Thank you. So getting back to the National Lung Cancer Screening Trial, this is really what the landmark study was that indicated lung cancer screening is beneficial. They enrolled 53,000 people. And this is about, I think the studies came out about 10 years ago. 53,000 people, and it compared low-dose CAT scans versus chest X-ray follow-up for 3 years. Now, the reason why they did chest X-ray, because traditionally that's all we had. And then they actually did a lot of studies in the 70s and 80s on chest X-ray screening, and they found that it didn't give any benefit. They found cancers, but it wasn't early enough to do anything about it. So that was kind of the standard of care at that time, and they weren't recommending screening. They selected a high-risk patient population, so 55 to 74 years old with a 30-pack year history of smoking. A pack year is basically I smoke 1 pack a day for a year. That's 1 pack year. So you can imagine 30-pack years, what that translates into. The patients had to either be current or former smokers, and they had to quit less than 15 years before. And actually the trial was stopped early because they did see the benefits. Next slide, please. So what was the results of this trial that led to kind of the whole screening development? So they actually found a 20% reduction in lung cancer deaths in those who were screened, which, I didn't include this on the slide, but that is on the order of what colonoscopies do for colon cancer, and is actually more effective than what breast cancer does in mammographies. And in addition, they actually found a nearly 7% all-cause mortality reduction in the screen group. So this is patients that not only did better with lung cancer, but they found aneurysms or other medical problems that reduced the mortality in those patients. And what was really telling was the number of patients needed to screen to prevent 1 lung cancer death was 320. Now, when I read that, I'm like, that seems ridiculous. We're going to screen 320 people to save 1 lung cancer death. But when you compare that to generally accepted screening programs like colon cancer and breast cancer, the number needed to screen for colon cancer with a colonoscopy is over 2,000. That's to prevent 1 colon cancer death. And the number to screen breast cancer is almost 2,000. So you can see lung cancer was so much more cost effective in that regard to screen. It prevents much more lung cancer death in comparison. And the main difference was the detection of more stage 1 cancers in the low dose group, and it also less stage 4 cancers in the 2nd and 3rd years of follow-up scans, which really suggests that we were diagnosing these things earlier, which was leading to the mortality benefit. And since this study came out, there's been several other studies that have confirmed and refined the numbers a little bit as well. Next slide, please. So who gets screened? Well, up until very recently, the U.S. Preventive Task Force really used this lung cancer screening trial as the basis for who was included for screening. So up until a few months ago, age 55 to 74, the 30-pack year history of smoking, and the current or former smokers less than 15 years ago. That's who was included in the trial, so that's what the U.S. Preventive Task Force recommended. However, based on more recent data and some other factors, that has now expanded, and this is really hot off the presses because it happened in really mid to late March, where they updated their recommendations, and it expanded it to age 50 to 80 and dropped the pack years down to 20. And of course, it's still having the current or former smokers who quit 15 years ago. Next slides, please. So why did this change? And there was 2 main reasons. One was using the old guidelines, only 15% of the eligible patients were getting screened by previous guidelines. And whether this was lack of buy-in by the medical community, lack of interest, and lack of knowledge about it, they didn't really could explain why this was happening. So by doing this, expanding the age range and lowering the smoking criteria, they would actually make more patients eligible for screening, which actually nearly doubles the potential patients that can get it. And the eligibility expansion was also really viewed as a way to get more inclusive of women and African Americans. Both groups have been shown to smoke less cigarettes than Caucasian men. And African Americans actually inherently face a higher risk of lung cancer anyway than Caucasian men to begin with. So they felt by expanding it, you're going to allow more individuals, more patients to get covered by this. And then the question is, will insurance cover this? And the answer is yes. However, that comes with a caveat. At this point, most, if not all, insurance carriers these days cover lung cancer screening CTs for eligible patients. However, it did take 1 to 2 years after the original recommendations for the insurance carriers to cover the screening. Usually what happens is the screening happens, the recommendations come out, Medicare decides to follow it about 6 months to 12 months later, and then the insurance carriers that are competing with Medicare will follow that about 6 months to 12 months later. So there is always a delay on this. So I would always recommend checking with your insurance company. They'll cover the original. So if you're in that 55 to 74 with 30 pack years, that should be covered. If you're in the expanded recommendations, it may not be covered yet, but it should be in the next year or two. Next slide, please. So what now? So what's the process? What that happens? So certainly you can always discuss with your doctor, which is where most lung cancer screening discussions happen, or if you're seeing myself, or your pulmonologist, or any person at Allina. Allina does have these lung nodule clinics as well at some of the bigger centers, Abbott, Mercy, United. And if this is going on to non-Allina people, Health Partners I know has lung nodule clinics, Fairview does. So pretty much all the big centers have these kind of clinics designed for lung cancer screening. And the discussions usually include some semblance of shared decision-making, which is really you're talking to one of the experts about the pros and cons of lung cancer screening in you and to help determine if you're eligible. In particular, since I obviously am with Allina and our lung nodule clinic at Mercy, the lung cancer screening is done by Cheryl Jarvis. She's one of our nurse practitioners, and she does a great job and follows a lot of these patients. And if you're eligible, and she does go over this kind of stuff, and you decide to proceed, then you'll get a low dose CT scan for lung cancer screening. Next slide, please. So what happens if, this is kind of the next steps. What happens if you have no lung nodules or any other concerning findings? Well, then it's routine annual low dose CT screening for at least 3 years. Again, that's what the studies did, was 3 years. Doesn't mean you might not even extend it on. I'm not suggesting if you're 50 and start doing this and do it till 53, then you're in the clear and you're not gonna have to worry for the next 20 years. So those are ongoing decisions that can be made with your provider to change the time frame. If you see small nodules, which is extremely common, and actually probably the most common consults we get in the nodule clinic, usually it's some sort of routine CT follow-up at varying intervals, 3, 6, 9, or 12 months. And we follow these things for up to 2 years. If they're stable for 2 years, in most situations, no more follow-up scans are needed, and the nodules are considered benign. Most nodules that are less than a centimeter in size are benign, over 95%. So, that is one of the big talking the patients off the ledge when they come in with a 5 millimeter nodule. That's some of our work that we have to do, because they think, as soon as they see something wrong, it's cancer. When you immediately tell them that it's, you have a 2% chance this is cancer, all of a sudden the weight has been lifted off their chest per se. Next slide, please. If something's bigger, so if you have something greater than 8 millimeters, you're likely going to be referred, at least in the Mercy nodule clinic, to one of our Allina pulmonologists, myself, Dr. Naima Adhami, or Dr. Brad Chmielewski, and we'll discuss the next steps. Other systems, I'm sure, have nodule clinics and probably do something very similar, but I can't really speak on those institutions. Usually this could be either A, you're going to repeat the CT scan at varying intervals, like before. You might get a PET scan, which is a different type of radiology test to help determine if a biopsy is needed and where would we do a biopsy on the body. And then we'd also discuss biopsy routes. If a PET scan is done, and be aware, another thing is that a positive PET scan, which means it's kind of lighting up, does not mean it's cancer. It usually means something needs to be biopsied, but there are a lot of things that can cause PET scans to be positive. Next slide, please. So how do you get biopsy? So there's really 2 ways. You can do it from the outside, which is usually a CAT scan biopsy. So there's a little picture there of, you're in the radiology suite and the interventional radiologist is kind of injecting the needle, and you're obviously numbed up. And usually you're given a little something to take the edge off. It's normally not done under general anesthesia. It's usually done under some conscious sedation at most. Or you can go from the inside, which is called a bronchoscopy, or there's even surgical biopsies. And usually these are done either with conscious sedation or general anesthesia, depending on the type of procedure we're doing. And we're going down in the lungs looking for something. That bottom picture is just a random picture, again, found off Google Images, that of a airway that you can see a tumor sitting right in the airway, and we can sit there and biopsy that. Next slide, please. What happens if you get the cancer diagnosis? Well, there's a good chance you're going to need some other form of tests, maybe an MRI of the brain, maybe breathing tests, because this all helps with staging and helps decision-making for your treatment plan. You're probably going to be referred to some other specialists, a medical oncologist for either chemo or immunotherapy, maybe a radiation oncologist for radiation, or a thoracic surgeon for resection. Next slide, please. And this slide I just included there because I get a lot asked about, well, what about the treatments? You know, I don't want chemo and all that. These are generalities. Not everything fits with every person, but usually treatment is based on a variety of factors of both the tumor itself and the patient factors, such as age and comorbidities. In general, small cell is only treated with chemo and radiation, you know, plus or minus immunotherapy these days. If it's non-small cell, which is about 80% of lung cancer, usually early stage 1 and 2, surgery, if you're able to get surgery, plus or minus chemo. If it's stage 3, it's usually chemo and radiation plus or minus immunotherapy. And stage 4 is usually chemo plus or minus immunotherapy, and radiation is usually palliative. So those are generalities. Not everybody fits into every one of these categories, and there are exceptions to the rules. I think that might be my last slide. Next slide, please. Oh, so a recap. So a recap in a nutshell, it's a lot better to diagnose at the stage with a nice big red arrow where it's a tiny little lung cancer screening, tiny little nodule, versus something where on the right side of the screen when it's at that size, where it's much more advanced and much more difficult to treat at that point. So thank you very much. Next slide. I appreciate it.
Thank you, Dr. Baker. Thank you, Dr. Baker. We plan to host a low-dose lung cancer screening event in the fall. Stay tuned for more information in the upcoming months regarding the date and a time that will be held here in Buffalo. Lastly, rounding out our educational session today, we have Stacy Bessinen. Stacy is the Wellness Program Specialist at Buffalo Hospital, part of Allina Health. Stacy will be sharing information regarding tobacco cessation and behavior change. Go ahead, Stacy.
Thank you. So we just heard a lot of information about the effects of vaping, smoking, and radon levels, and it can be very overwhelming. And so our goal is really to empower you to make positive changes and take the steps to prevent lung damage, to live your best life. And behavior change is a process. And for humans, sometimes these processes can be hard to implement or change, whether it be quitting smoking or vaping, taking the steps to test for and mitigate for radon, or even getting a lung screening. So this is where behavior change really comes in. Next slide, please. And so first we're going to start out with smoking and using tobacco. And so when we're looking at this, I really want you to, think about, if you are a smoker and you'd like to quit. I'm really impressed oftentimes when I work with people who are smoking, all the stress management techniques that go into actual smoking. They're taking a break, they're going outside, getting some vitamin N for nature, they're social interacting and connecting with others, and they're taking these deep breaths, and so just thinking about what takes place there's a lot of really good things. And so as it relates to our habits form when we do things over and over, and we make things very easy for us, and even in that process. So when I work with people who are smokers, I think about, the self-care, what do they have to do to put the smoking into place to make that happen? And there's a lot, and that's that process that we're thinking about as it relates to behavior change. And so the first thing I do is work on that awareness. So what do you need in this moment? So as a smoker, if you need that cigarette, and so what I do is I ask them to kind of stop themselves and say, okay, what's going on in this moment? And if they say to themselves, I really need to go out and smoke, yeah, go ahead, go out and smoke. But what I recommend is going, taking your break, going outside, talking to those others who are there, taking a few deep breaths, and then asking themselves, okay, how am I feeling? Do I feel like I really need the cigarette? And sometimes the answer might be no, and that's a good thing. Sometimes it might be, yep, I do. So then it's a step after that. Do I need one puff? How do you feel after that? Do I need half a cigarette? Maybe you need a full cigarette, maybe you need two, or as it even relates to vaping. So it kind of allows yourself to stop yourself in that moment and say, what do I need? Because oftentimes habits, they're just so ingrained. So then we go in and we don't even realize it, and all of a sudden we've smoked or vaped, the whole cassette or 3-4 cigarettes, and so oftentimes stopping yourself and just having that awareness is key. So next. So I also want to go into kind of changing that question to really build on our own resiliency. This is a really good question, especially when you go to the doctor. And I know a lot of physicians are changing this question as well. Oftentimes you go in and the doctors say, what's going on? What's the matter with you? And you'll say, well, I have high blood pressure and I'm overweight and I'm smoking and I'm not eating very well. And so the doctor will say, okay, well, eat better. Here's some blood pressure medication, go for a walk and quit smoking. And here's some brochures for that. And here's a picture of my mom with her 2 little grandkids, who these boys are now 14 this year. And so what happened was she had all of those same symptoms and issues that I just talked about. And she went into the doctor and the doctor changed that question. The doctor said, what matters to you? And at the time, my sister and I were both about to have babies. And she said, my grandkids are very important to me and I want to be around for them. So the doctor said, well, lower your blood pressure. Here's some medication, go for walks, eat better, exercise and stop smoking, and gave her the pamphlets to go along with that. And so this isn't always the case, but she was able to quit cold turkey just because of that one question. And you can question yourself at any time. You can question yourself right now, like what really matters to you, really connecting your values to to internally motivate you to make some behavior changes around your health and wellness to really be able to live your best life. Next slide. So when we're looking at behavior change, we're looking at, do you want a temporary or versus a permanent change? And that can be really hard to kind of think about. So in this process, it's a step. It's all about that awareness. To take some time and really think, what are your values around this? What changes do you need to make? It's amazing what you as humans, if we do smoke or vape, what steps we need to take in order to make that happen. And so when we adjust our behavior versus a lifestyle change, sometimes it can be around diet, it can be around smoking or vaping, or even testing for radon, or even going in and making a screening appointment. It all is a process. So really allowing yourself some grace and time, and to really sit back and take a deep breath and make those small little changes. Making sure that the behavior change is really realistic for you and sustainable. That is also very important, those small changes. And then really thinking into the future, like what do you envision yourself to be in 5 years, 10 years, tomorrow, next week, any time, like just really getting that in vision. And what are you trying to change, and why are those changes important to you? So really linking those back to your values. Next slide. So let's take a closer look at yourself. And these are just some questions to ask yourself. Like, what do you want for yourself? What's your end goal? What are your barriers and constraints? I mean, that's very important to just note. Because if you have a lot of barriers in your path, it's going to be harder to do some behavior changes. And so before you even start, there might be some barriers that you need to break down. What support system that do you have? Support can be very, very important. And then what is your motivation? So kind of getting back to your values. Next slide. And then we're also looking at failure versus success. Like I had mentioned before, around smoking and vaping and taking those breaks and getting outside, there's a lot of success in that. So we can build on that and act on it and do, you know, we already have that habit put into place of going outside and taking those deep breaths. So how can we have that awareness? Oftentimes we allow ourselves to be identified by our failures and forgetting to celebrate our successes. So even, you know, ordering up and getting that radon test and starting that process is a success. Making an appointment to get a screening is a success. Just every single point on that process is amazing and a success. So we want to concentrate on those positives and not dwell on the negatives. You know, you're working as hard as you can to make some good positive lifestyle changes, and it takes time, and that's okay to allow yourself and give yourself some grace. And ask yourself in that process, what did you accomplish? What are you proud about in your life? And where did you succeed? Kind of even looking back in your past and thinking and reflecting on those times that you did have some success. You know, answering those questions and how you succeeded and what processes did you put in place to make that success happen? Because we can learn from what we did in the past. Start believing in your ability to make the changes, you know, and definitely getting rid of the guilt. You're only human, we are only human, and nobody's perfect. And so we're just doing our best to make those behavior changes to live our best life. And like I had mentioned before, small changes over time bring big results. You know, it's the little things, it's the daily things. It's taking a step back and just taking a deep breath and saying, okay, what do I need in this moment? If you're stressed or if you're not sleeping, or if you need to make that appointment, or if you need to you know, test for that radon, whatever it is, it's taking that first step. It can really make big results for your future and for your overall health and wellness. Okay, and then definitely there's a goal setting process in all of this. You know, we can always start with you know, our big goal, and then we want to break that down into smaller goals. So making some small adjustments, you know, one at a time. Meet yourself right where you're at. You know, how are things, like if you're trying to quit smoking, but your life is really, really stressful right now, we're looking at, okay, so maybe right now is not a good time, but I'm still going to bring in some of those awareness tools to say, okay, I'm just going to go out for a couple of deep breaths and see how I'm feeling. If you've never done that before, it might be something to give or worth a try. And no change is ever too small. So building your self-confidence and your self-esteem by sustaining any change, big or small, is a huge accomplishment for us as human beings. Don't try to address all your goals at once. That can be very overwhelming. Just like, you know, some of the information that we heard today, you know, very, very good, but sometimes that can be very overwhelming. So definitely taking the first step and going from there. And then remember, some small changes, and some changes will occur in stages, but the end will produce the result we're looking for. So definitely setting some small daily goals to make that big goal happen for you is always a first step. And last is, you know, I kind of already talked about this. The motivation is so very important, and what I really like to do is link any goal or any plan that you have back to your values. You know, thinking about what really matters to you. And so, but sometimes people need more of a carrot or a stick, or, if they're going for something, they're going to they want to quit smoking because they want to be healthier. They want to be around for their grandkids, like my mother. Otherwise, sometimes people are running away from something, like they're running away from maybe a family history of lung cancer. And so what does motivate you is kind of a very important thing to just put to just have in mind, to be able to make those small steps. Yep, so we'll be around for some question and answer. Back to you.
Thank you, Stacy. That was also informative, and I hope our participants learned a great deal from our presenters. It is now time to open the floor to ask our experts any questions or clarifications you may have. You can raise your hand and we can call on you to speak in the Zoom call, or you can use the chat function to type in your questions.
Okay, it looks like we have a question here in the chat. It says, I was told by a company that a mitigation system for them just to make money off of you. What is your thoughts on this?
Hi, yeah.
Mark, that looks like it's a little bit more towards your presentation.
Yeah, so this is Mark with the Minnesota Department of Health. So, really we're advocating for radon mitigation systems. They are proven effective. People do a lot of training for this. They basically take a 5-day course, and then after that, they have to pass a very difficult exam. And it's because they do a lot of diagnostic testing to figure out where that radon pipe is going to go, what type of soil it is, so how deep the hole has to be dug in the bottom. Really what it is, if you think of it this way, it's like a straw, and someone's sucking out the top of it, which is the fan, and it's taking the air out that way. And around all those cracks and crevices I talked about, they're going to try to seal those up, put a covering on that sump pump, or over the crawl space, they have a Mylar sheet they put over it. So anywhere there is a space that rain can get in, they're going to stop it, make sure it goes up that pipe. So scientifically, it's very plausible thing, and it does work. We've seen radon systems go down from even in Pennsylvania, where they get up to 1,000 picocuries per liter, down to 1 or less. So it's a very well done thing, and installers are professionals and they know how to do this.
It looks like there's a couple other questions here. I want to make sure an installer for mitigation is reputable. Is there a list somewhere that Minnesota Department of Health has of reputable installers for these mitigation type systems?
Yeah, so back in 2020, we had all of the people who do radon mitigation installations are now certified, meaning certified professionals. So they have to go through all this training now, and we've listed all those people on our website. So just Google, basically the easiest way to do it is just Google MDH radon. It'll bring you right to our website, and then on the left-hand side or tab is a list of licensed mitigation professionals. And you put in your zip code, and and you put in the radius at which you want to find them, like a 30-mile radius or whatever, and then they'll come up. And they usually do free estimates. They'll come out and give you an estimate. So all those on our website are reliable and professionally licensed.
It looks like somebody may have had a radon mitigation company come out. However, they said that their results were not usable. Is there a time frame that these values are good for if you do a radon test?
Generally, we don't have, there's not a set standard, but we don't want radon test results from a couple of years ago. We want a radon test result from like probably that month or two would be really nice, because as the seasons change, radon results do change. But really as it is, we like the last year's winter months as a really good indicator of the radon levels, because during wintertime, radon levels are generally about a picocurie per liter higher. And that's the most accurate time. So if like you have a test done in the winter and then you have someone out in the summer, I think those test results are fairly reliable and accurate. If you have results from a couple of years ago, then I would say those are not as accurate, and you should redo that.
Wonderful. And since we have you on the line, Mark, we had prepared one question for you. Does radon testing need to be done when moving into a new house or with any real estate transactions? Is that a requirement here in Minnesota?
It is, real estate testing of the home is a requirement. Oh, no, not a requirement, sorry. Gosh, now I, it's so funny. You know, I have to say, I've been doing COVID work for the last year and a half and getting into like radon work. And I'm like, oh my gosh, you know, you kind of forget things. My gosh, which is embarrassing. But COVID's taken over my life for the last year and a half. So radon, during a real estate transaction, you could basically, yeah, I think you're gonna, sorry, you don't, no, oh my gosh, now I forget it. I'm like totally mind blanking. So thank you for that question. But now I don't have an answer for you. I'm gonna have to look that one up, but I think that during a real estate transaction, do you have to test? Gosh, everyone's gonna be yelling at me back at work because I can't answer this. Oh my gosh. See, this is the problem when you're on COVID brain for so long and you have this. You know what? Do we have a second? I could Google it.
Yeah, let's move on to some other questions
Okay,
that we
we'll do
have
that.
that we have prepared, and then you can get the floor here again when we're through. One of the questions that we prepared was, what can I do to stop my teen from vaping? Is there any direction here for parents of teens that, you know, have the ability to purchase these devices?
That's a very good question. One that we've gotten quite a bit as vaping has increased for sure. I think the biggest thing to first do is just to be aware of what devices are popular, what devices are being used, so you can recognize if your teen's using it. The other big thing is we all commonly get asked, how do we know if an adolescent's using? And it's difficult in many ways because a lot of the signs and symptoms of someone that's been using nicotine at a younger age is the irritability, the frustration, the wanting to be separate from their family time, stuff like that. But a lot of those same symptoms can be said for someone just going through adolescence. For if you find that your teens are using or your adolescents are using, I would say the first things first, the best thing you can do to start out is just have a conversation with them, have a very open and honest conversation about what their use looks like, why are they using. Many times we hear that individuals are using to fit in or to manage stress and anxiety. If it is a stress and anxiety piece, then having the conversation of what are better ways to do that. Motivational interviewing, that positive reinforcement of getting them to realize that there are better alternatives out there. Otherwise, I will say one thing is, with it being T21 within Wright County, with it being T21 nationally, if they are younger in purchasing, then there is always the question of where are they getting it from, how are they getting it, and maybe trying to figure that out, but maybe not focusing on that and really just having a conversation about where they're at mentally and physically.
Do you think the T21 laws have helped with decreasing younger people from using tobacco?
I would say yes. However, I will say a lot of due to COVID and a lot of other things, the long-term studies, or I guess the stats for Wright County specifically haven't come out yet. We do know that in other states that have done it, in other localities that have done it, they did see a drastic reduction in tobacco use in adolescents due to really putting in that simple stopgap of upping the age to 21. Along with that, for individuals, just speaking long-term for individuals, the younger they start, the more likely they are to continue using nicotine for the rest of their life. So it's something like, I'm trying to remember a statistic off my head, but if an individual starts under the age of 18, they are 90%, I'm blanking, but extremely more likely to continue on using tobacco products for the rest of their life.
Thank you. And then Dr. Baker, there's a couple questions here for you. Let's see, how many of the criteria do I have to meet to qualify? So is it just, do I have to be 50 and have smoked at one point in my life, or do I have to meet all of the criteria? Or am I eligible because I'm over 50 and I was exposed to secondhand smoke because my parents smoked? What, how does that criteria work?
So always keep forgetting about that. We're in the same room, so. All right. So for insurance coverage, yes, you really do need to hit the criteria that the insurance carriers are covering. So at least the old one was the 55 to 74 with the 30-pack year history of smoking, the either active or smoking less than 15, quit less than 15 years. And presumptively that's going to be the same going forward with the newer recommendations. We do get a lot of questions. It's like, well, I grew up in a family of smokers. I didn't smoke, but smoking runs in my family, or I should say lung cancer runs in my family. So I'm really worried. And I often will turn to the patients and be like, well, lung cancer probably doesn't run in your family. Smoking runs in your family. So it comes back to, this is still mostly an environmental cause of cancer, lung cancer, radon, smoking. So you really aren't technically eligible if you don't hit the criteria. Now, then there's the other, whenever we do our lung screening for nodules, we're also asking about asbestos and radon and other histories of smoking or other histories of cancer. And most often they're not necessarily going to be a candidate for lung cancer screening CTs, low dose CTs. That being said, I've had plenty of COPD patients that might have quit 20 plus years ago. They say, let's do a CT scan. It's not a low dose CT scan. It's a regular CT scan. And I'll say, well, we're doing it for quote unquote your cough, even though I will tell the patients, we're really doing it for lung cancer screening to look for spots in your lungs. So, I mean, there are, I hate to say, and this is not intended to be fraud or anything like that. You are trying to find ways around some of the criteria for some patients. But if you were the question on here where if you've never smoked, are you eligible? No, I mean, there wouldn't be an indication to do that for those kind of patients.
Thank you, Dr. Baker. And then for you, Stacy, it looks like there's a question. Is the behavior change activities you talked about something you need to do for a certain period of time to be successful, or is it for a lifetime?
Yeah, it's definitely a good question. So with anything, with any goal, it is putting those processes and steps in place to make it a habit. And so once it's a lifestyle habit, and once you got it, it's ultimately meant to be a lifestyle. So it's easier to have a lifestyle change that you're comfortable with, that you don't even have to think about very much anymore. It's just something that you do. So yes, it definitely, the ultimate goal is for it to be a lifestyle and over a lifetime.
Thank you. And I just want to call it to the group. It looks like Mark did get back to us. Testing during a real estate transaction is not required, but it is, however, up to the seller and buyer to negotiate.
Indeed,
Do any of
sorry about
our
that.
participants have any more questions at all? I just want to go ahead and call out that Buffalo, sometime here in the fall, is going to be hosting a low-dose lung screening event. So that will be here local in Buffalo, in Wright County. So you will not have to travel to the metro to have that screening test completed. Whereas you may normally have to go to Mercy or Abbott or a lung nodule clinic to have that done. We are going to offer that here in Buffalo. So keep your eyes out for a plug for that. Once we have a date and time set, we'll be promoting that event here in the near future. Yeah. Go ahead.
I do want to stress that you don't need an event to get screened either. It's nice to have those, but the radiology department here does do lung cancer screening, at Buffalo. So, if your patient's eligible, if you're eligible, if your patient's eligible, you can still go get that. So.
And then one more question, who do I talk to about this? So is my primary care doctor the best one to talk about any concerns about lung cancer, or who should I be reaching out to with those concerns?
I would always say your primary is probably the best one to initially reach out to. Because most screening is still done by the primary care docs. They don't send them on to the pulmonologists or the lung nodule clinics in most situations. And they know you best. They know the patient best. They know the family's dynamics. So I think that's still a great starting point. If there was ever questions, you can always go to one of the nodule clinics and do screening questions in that regard for lung cancer screening. But I would highly encourage it to be the primaries.
Wonderful. Thank you, Dr. Baker. At this time, I'm going to pass it off to Kelly here again.
I would just like to thank the participants for joining us today. It was great to share the afternoon with you and learn from our wonderful panel of experts.